Something quietly alarming is happening inside America's consumer safety system, and it directly involves your private medical records. The Consumer Product Safety Commission, known as the CPSC, is the federal agency responsible for protecting Americans from dangerous products. For decades, it has tracked injuries through a program called NICE, the National Electronic Injury Surveillance System. This system relied on trained human contractors stationed inside hospital emergency rooms, carefully collecting data on product-related injuries. But that system is now being dismantled, and what is replacing it raises serious questions about patient privacy, government authority, and the future of public safety data in America. For years, agency officials discussed moving away from human contractors and automating NIST to save time and money. The concern was efficiency. The solution, however, has introduced far bigger problems. Without workers physically on site, hospital staffers may no longer receive the training needed to determine what clinical information is actually important to report to the CPSC. In other words, the people feeding data into this system will no longer know what truly matters, and that threatens the quality and reliability of the safety data the agency collects. Alexander Hohn Sarek, one of the Democratic appointees President Trump fired last year, and the CPS former chair, put it plainly, they want to suck in as much data as possible. But I'm not sure how thoughtful they're being about what is collected and what is actually needed by the agency. That concern is not just philosophical. It points to a fundamental shift in how the government is approaching your health information. At the center of this shift is a private organization called Kansa. The CPSC has brought in Kansa to collect emergency room records directly from hospitals across the country. And the scope of what Kansa is collecting goes far beyond what the CPSC has ever gathered before. In an email sent to hospital technology officials, CPSC Chief Data Officer Elizabeth Puchek outlined that Kansa would provide the agency with patient records when someone is treated in the ER for any of more than 10,000 conditions. That is not a small number. That is virtually the entire spectrum of emergency medicine. Here is where it gets more troubling. The CPSC's own 214-page operating manual instructs hospitals not to include identifiable information such as names, birth dates, or addresses when reporting cases. The agency is only supposed to receive patients' identifying information when needed for follow-up investigations, which happens in fewer than 1% of reported cases, according to the manual. The CPSC has also historically limited the records it collects to minimize privacy violations in case of a data breach. That caution was built into the system for good reason. From 2017 to 2019, the agency improperly released personal health information of around 30,000 people, a disclosure that a top Republican at the time called concerning. That breach was not hypothetical. It happened. And now, Kansa will be receiving even more sensitive information on far more people than were ever affected by that earlier incident. McCrary, a representative associated with the new program, stated that Kansa will remove patients' names, addresses, and medical information not needed by CPSC before sharing records with the agency. But the decision of what is and is not needed is being left to a private contractor, not a government agency accountable to the public. Jessica Hoffman, a professor at Case Western Reserve University, has flagged exactly why this matters. Leaving a private organization to collect sensitive health information introduces serious risks, including the possibility that data could be stolen or used for commercial purposes. Very often, they will use information for marketing because now they're going to know what conditions people have, she said. The CIP's spokesperson, Roney, responded that the contract with Kansa, which has not been made public, prohibits the organization from selling or marketing the data it collects. But a contract that the public cannot read offers little reassurance. The list of conditions Kansa is collecting data on makes the situation even harder to explain. The The CPSC has jurisdiction only over certain consumer products. Its own manual specifically identifies types of ER visits that should not be reported injuries caused by food, illegal drugs, medical devices, alcohol, or plants, as well as injuries that did not involve consumer products at all, such as a cut from a rock or broken bones from falling on the ground, and suicide attempts by adults. Yet in a contract offered to one hospital and reviewed by KFF Health News, Kansa set no such limits on the information it would gather from ER records and said it would hold on to patient health information for at least 30 days. The expansive list of diagnostic codes Kansa provided includes injuries that have absolutely nothing to do with consumer products. Child injuries resulting from poisoning by vaccines, not a consumer product, and contact with stingrays, also not regulated by the CPSC, are both included in the list. There is no coherent regulatory justification for the CPSC collecting data on stingray injuries or vaccine reactions. None. And yet the system is being built to capture exactly that kind of information. It is also worth understanding the pressure being placed on hospitals. CPS Chief Data Officer Elizabeth Puchek, who joined the agency late last year after previously engineering the data system for U.S. Citizenship and Immigration Services, has told hospitals in emails that they must seek a formal exemption from the program if they decline to share patients' emergency room records with Kansa. The burden, in other words, has been placed on hospitals to opt out, not on the government, to justify why they should opt in. The CPC's outreach has targeted some of the largest health systems in the country, including urban and rural hospitals, as well as small, publicly owned facilities. Staff members at Mary Greeley Medical Center in Ames, Iowa, said that Kansa and federal officials told them their participation in the new program was mandatory. The hospital, which had long participated in NICE, signed a new contract in April to share its ER records with Kansa. It is now re-evaluating that decision after being informed that the funds it received to participate in NICE were no longer available. Not everyone is complying. Harborview Medical Center in Seattle made its position clear. Spokesperson Susan Gregg stated that the hospital's emergency room has voluntarily submitted de-identified data for many years, but we are not obligated to report this information. In Boston, Mass General Brigham declined to participate entirely, with spokesperson Kelly Mitchell explaining that to protect patient privacy. We are unable to provide these medical records. Major health systems, including Henry Ford Health in Detroit, St. Luke's in Boise, Idaho, and Sanford Health, based in Sioux Falls, South Dakota, which together handle over 1 million ER visits a year, have been approached, but have not yet entered into agreements with Kansa. Several of the nation's busiest hospital systems, including the Mayo Clinic in Minnesota, Yale New Haven Hospital in Connecticut, Nationwide Children's Hospital and the Cleveland Clinic in Ohio, and Baylor Scott and White Health in Texas declined to answer questions about whether they are participating. That silence speaks volumes about the uncertainty and discomfort surrounding this program. Hohen Sarek, the former CPSC chairman, said he was genuinely surprised by the agency's approach. This idea that they can simply demand patient information from a hospital and that the hospital would provide it, I really don't understand the basis for that, he said. Several hospital executives, lawyers, and others have echoed that skepticism, raising serious doubts about whether the CPSC even has the legal authority to compel hospitals to hand over this data. What started as a modernization effort, automating an outdated injury surveillance system, has evolved into something far more expansive. The CPSC is collecting data on conditions far outside its regulatory authority. Through a private contractor operating under an undisclosed contract, pressing hospitals to comply by framing participation as mandatory and gathering more identifying patient information than its own rules permit. A program designed to track whether a toaster burned someone has become a mechanism for collecting the emergency room records of millions of Americans. And the public, whose data this is, has had almost no say in the matter.